Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through fluid and electrolytes. Let's begin by talking about crystalloid solutions. Crystalloids are one large group of fluids, and within crystalloids, we have three subgroups. The three subgroups are isotonic, hypertonic, and hypotonic. Let's begin with isotonic, because this is by far the most used type of fluid in healthcare. Within isotonic, we have a number of different fluids. We have normal saline, which is also known as NS 0.9, sodium chloride, and NaCl. Another fluid within isotonic is D5W, or dextrose 5% in water, lactator ringers, or LR, and plasmolite. We use this to give a patient fluid for any number of reasons. They could be dehydrated, they could be bleeding out, they could have a lot of different reasons, but the patient needs fluid, so we give them fluid. One quick note, if a patient's getting fluid because they're bleeding out, we prefer to give them blood, but that's a whole separate lecture. Next, when we're talking about isotonic fluid, I said we're talking about the most common type of fluid that we use in healthcare. And within isotonic, the most common one is normal saline. However, very often, depending on the unit that you work in, maybe a burn unit, maybe an OB unit, they tend to prefer LR for certain patients. D5W is often preferred in children. So it depends on the unit you work, what will be the default fluid, but generally speaking, it's going to be normal saline. When a patient's getting a bag of normal saline, please always check the bag, because sometimes we add things to it, such as sodium bicarbonate or potassium can be added to a normal bag of normal saline, and it'll just still look like a normal bag of NS, but it's going to have a label on it that it has extra contents in it, or it actually does come that way pre-made from the manufacturer with some of these extra things such as potassium. Be very careful, because the second we put anything else in it, it's no longer a bag of normal saline, and it's going to be completely different and have completely different consequences for your patient. I want to make a quick note about D5W, because I've seen this in a few nursing test banks. D5W, when we give it to the patient, it's isotonic. However, once all that dextrose, the 5% of it that's dextrose, once all of that gets consumed by the body, gets used up as glucose, which is very quickly, once all that gets used up, all that you're left with, the D5 is gone, and now you just have water. Well, plain water is hypotonic. So again, D5W is considered isotonic, but you are expected to know, really just for nursing test purposes, that once it is administered to the patient after the dextrose is metabolized, now it's just water, which is hypotonic. Next. The next type of fluid we have is hypertonic. When we talk about hyper and hypotonic, one of the most important things you have to understand is that these cause a fluid shift. It's very difficult for me in this video to get into what exactly that means with fluid shift and how exactly it causes it on a molecular level, but let's just understand this. When you give a patient hypertonic fluid, it is going to shift fluid from the cells into the blood. It's going to shift fluid from the cells into the blood. And hypotonic is going to do the opposite. So hypertonic solution includes 3% sodium chloride, or NaCl. It also includes D5 in NS. Next, we have, what do we use this for? We use it when we want to pull fluid into the blood, usually so that it can get to the kidneys and the kidneys can get rid of that extra fluid. Hypertonic solution is always given through a pump, same as hypotonic. Even normal saline should be given through a pump, though it doesn't have to. Next, we have hypotonic solution. Hypotonic solution is 0.45%, which is also known as half normal saline. They also make 0.33%, which is known as a third normal saline. The indications for this is the opposite of hypertonic. This is where we want to push fluid from the blood into the cells. It's called cellular rehydration, when we want to rehydrate the cells. And this one also, because it's involved in fluid shift, that's a very big deal to use these medications, these fluids. So those also need to be given very carefully, need to be given through a pump. Next, those were the crystalloids. We had isotonic, hypotonic, hypertonic. Now we have colloids. Colloids are another type of fluid, but these have a few big differences between them. Let's first see what we're talking about. This is going to be albumin, which is a blood product. It's something that we get when people donate blood. Dextran 40% in D5W is another colloid. PPF, or plasma protein fraction, and hetastarch 6% in NS. All of these are called colloids. I do want to warn you for nursing school. A lot of these things, such as D5W versus D5NS, those are different. D5W is isotonic. D5NS is hypertonic. Same thing down here. Dextran 40% in D5W comes in other variations. So does hetastarch 6% in NS. Look very closely at the question you're being asked on your test to make sure they're not trying to trick you and they're using one of the common ones and not throwing you for a loop with using one of the less common ones that I haven't even listed here, because there are tons more. Next, the indications for giving colloids is to increase volume in central circulation. I know that sounds like the same reason we would give fluid anytime. We're trying to increase their volume. But with colloids, they have one distinct factor. Colloids stay in the blood longer. When we give a patient fluid, over a period of time, this fluid is going to no longer be inside the blood. So in our blood system, in our cardiovascular system, a healthy average adult male has roughly 6 liters of blood. If I give you a liter of NS, a liter of normal saline, well, now you have 7 liters of fluid floating throughout your blood system. Over time, roughly about an hour or so, a large portion of that liter I just gave you is going to be gone. Other cells are going to use it. It's not considered a fluid shift. Let me be very clear on that. It just leaves the central vascular system. So over time, it goes away. And if I still need you to have that more fluid, I have to keep giving you more fluid. Colloids have a distinct characteristic that colloids stay in the blood significantly longer than NS. So if I want to give you volume and I want it to stay in your blood system, in your central circulation, I would give you colloids over NS if I'm wanting it to stay in there longer. Okay, colloids are not as readily available. They're more expensive. They're a touch more complex, so they're not used as much. But if I wanted to stay in your volume, in your blood system longer, I would prefer to give you colloids. And the reason they do that is because they're larger molecules. The most commonly used one is albumin. I already mentioned albumin is a blood product. I didn't mention that because it's a blood product, make sure you're getting that special blood consent that you need to get anytime you give a patient blood product. Now let's move on to electrolytes. We have potassium. It's available PO or IV. Potassium is obviously an electrolyte that's used in our body. It is required for nerve impulses, muscle contractions, and so much more. Good dietary sources of potassium are bananas, spinach, oranges, and so much more. What do we use this for? We use it for a patient that is hypokalemic. Why would a patient be hypokalemic? Could be for a lot of reasons. It could be post-dialysis. It could be that they've gotten too much diuretics, or it could be they're not eating enough potassium in their diet. It could be a lot of reasons. What are the signs and symptoms? Hypokalemia can cause muscle weakness, anorexia, nausea, and vomiting. And hyperkalemia can cause dysrhythmias, paresthesia, and nausea. I will tell you, a lot of these symptoms are very vague, and a lot of these symptoms you're going to see over and over again with all the different electrolyte imbalances. I'm going to try to point out which ones are the key ones to know. Hypokalemia, muscle weakness, is definitely the most important one to memorize. And for hyperkalemia, dysrhythmias is the most important one to memorize. In fact, hyperkalemia can cause cardiac arrest. Potassium is very famous, or infamous, I should say, that it can be very painful when we infuse it via the IV. It's also infamous that it's a very large pill when it's taken PO. But anyways, when we're giving it to a patient via the IV, it can be literally painful to the arm as it's going in or wherever the IV site is. Because of that, we want to dilute the potassium as much as necessary to make sure the patient's not in pain. Also, we want to give the infusion as slow as possible to make sure the patient's not in pain. So we're going to dilute it and slow it down as much as possible in order for the patient not to have pain as it's infusing. IV potassium is never, ever, ever pushed. No exception, no such thing ever, unless you're literally trying to kill your patient. Because on death row, that is what they do. They give a potassium infusion, a potassium push to kill people. Next, whenever you're giving potassium, especially for test purposes, make sure you know the potassium level and don't be giving potassium unless you already know their potassium level. Next, because this potassium imbalance can cause an issue with cardiac dysrhythmias, make sure you are monitoring the patient's cardiac rhythm anytime you're treating them with potassium, whether it's high or low. When we give potassium, check the IV site very carefully to make sure it's intact and it's not leaking, it's not infiltrating, because if it does, it can cause extravasation, which can be a big problem with potassium. When patients take PO potassium, they should be educated to take it with food. If a patient ends up hyperkalemic, so here we're talking about giving a patient potassium, but if let's say a patient has too much potassium, if it is acute, meaning that they are having a medical emergency right now because of this hyperkalemia, we're going to quickly get rid of the potassium by giving them insulin and glucose. I'll take 1 second to explain how that works. When we give insulin and glucose, we all know insulin and glucose affects our blood sugar. Glucose brings it up, insulin brings it down. So technically, those two are going to cancel each other out in terms of the sugar. But while they're working to cancel each other out, they're going to shift a ton of potassium out of the blood into the cell, which will bring down our potassium level, which takes away that risk of acute hyperkalemia. If a patient has hyperkalemia but is not acute, they're stable, Then we would treat them with polystyrene sulfonate or pteramine. Next, we have sodium. And I should just mention over here, potassium, the terminology here is hypokalemia and hyperkalemia. Next, we have sodium. The terminology here is hyponatremia and hypernatremia. This is also available, PO and IV. Sodium is obviously, again, an electrolyte. It's heavily involved in fluid balance, in acid-base balance, and in neuromuscular functions. We would give a patient sodium if they're hyponatremic. Now, sodium is actually one of the most complicated ones to understand because sodium has a lot to do with fluid balance. For example, if a patient's severely dehydrated, they're missing a lot of water in their body, but if they still have the same amount of sodium, then it's going to look like they actually have a high amount of sodium. But it's not really that they have a high amount of sodium, it's just that they are lacking in fluid. So relatively, it looks imbalanced. If you didn't understand that, don't worry about it, but I'm just giving you a case in point about why this is so heavily related to fluid balance, because a lot of the sodium imbalances are actually fluid imbalances. Sodium is also a key ingredient in crystalloid fluids. If you remember from the first one, from the beginning of this lecture, we mentioned that NS normal saline actually has a sodium count. If you just check the normal lab on a bag of saline, you would see that it has a sodium level of 154, which is high. So it's a key ingredient in a lot of the crystalloids. Hyponatremia, what can cause it? If a person has excess fluid. So really, it's not that the patient has low sodium, it's just that they have so much water in their body that it looks like they're low on their sodium because it's not imbalanced. And it's something that can cause that is SIADH. Signs and symptoms: anorexia, nausea, vomiting, abdominal cramping, and progressive neurological symptoms. Hyponatremia can lead to a coma. That's the big one to remember. It can lead to a coma, and it's treated with hypertonic solution, possibly, or it can actually be treated with regular normal saline, because if their sodium level is at, let's say, 120 and they're at high risk of a seizure or coma, when we give them normal saline, that already has a sugar level or a sodium level of 154. That already will bring their sodium level up. We're going to bring their sodium level up extremely slowly. It says over here, the last line on the page, sodium cannot be corrected faster than 0.5 milligrams per hour. You are responsible to know that even as an RN. So since we're going to be doing it so slowly, we may very often, in cases of hyponatremia, give them just regular normal saline because we're really slow with fixing the sodium. Obviously, there are going to be cases where we're going to give them hypertonic solution to fix that more quickly if that's appropriate. Never more quickly, but more aggressively if that's appropriate. Next, hypernatremia. Causes of this would be kidney issues leading to the body not properly getting rid of sodium. I gave a quick example a few minutes ago. Also, hypernatremia could be that they just have they're severely dehydrated, so they have really low amount of water. So because of that, it looks like the sodium's high, even though it's not. The signs over here are thirst. That's the big one for hypernatremia, because again, this is almost always going to be dehydration related. And other things would be weakness, musculoskeletal, and neurological symptoms. Hypernatremia would often be treated with D5W. There is a broad variation of how exactly we treat this when this happens. Again, a lot of the times it's just that we need to give the patient some fluids. Sodium is often limited in those taking diuretics, meaning that we educate patients to limit the amount of sodium they take. If they're taking diuretics, if they have heart disease, if they have kidney failure, if they have heart failure, a lot of different times that we tell patients to limit the amount of sodium they take. So just consider that as you're going through and treating a patient with hypo or hypernatremia, whether that's something that has to be is a factor. Next, when we are treating a patient with sodium, we have to very closely monitor the sodium level because we can cause ODS. I don't think you'll see this on any nursing exam, but this is osmotic demyelination syndrome, and this happens from fixing the sodium too quickly. I say fixing, we're not. We're making things worse, but you know what I mean, that we're correcting it too quickly. Next, calcium. The term over here is hypocalcemia and hypercalcemia. Once again, it's available PO and IV. This is another electrolyte. It's used for nerve impulses. It's used for bone health. Muscle contractions and bone health are probably the two really big ones to remember. Where do we find this? In dairy products and fortified foods and juices. When do we give it to someone? When they are hypocalcemic. What are the signs and symptoms? Hypocalcemia can cause spasms, increased DTR, seizures, dysrhythmias, a whole lot of things. The two big ones you for sure have to know, because I've seen this on every nursing test bank, is Schwastik sign and Trousseau sign. If you don't know what those are, just quickly Google them or put another YouTube video on, not mine, that shows you what these are. But these are two of the most common tested on symptoms of hypocalcemia, or I should say signs. They're both signs, not symptoms. Hypercalcemia would be confusion, ECG changes, anorexia, nausea, vomiting, and fatigue. The PO version of calcium is usually connected to something, calcium carbonate, calcium gluconate, something like that. Whenever you're giving that to a patient, keep in mind that they're not all the same. 5 milligrams of calcium gluconate is totally different than 5 milligrams of calcium carbonate. So just consider that it's not all one and the same. If a patient's taking one and wants to switch to a different one for whatever reason, or bought a different one over the counter from what the doctor said, make sure you're double checking and confirming that they're still getting the correct amount. Whenever a patient has hypocalcemia, we're also always going to check their vitamin D. And if it's low, we always have to fix it. In fact, the general recommendation is anytime a patient has to take calcium, they should also be supplementing with vitamin D as well. Next, when specifically IV, the two versions of IV calcium are calcium gluconate and calcium chloride. Calcium chloride is 3 times stronger, more concentrated than calcium gluconate. Again, that goes back to what we mentioned, that you have to consider what is the element attached to the calcium when you are evaluating 2 different calcium packages. Next, we often give calcium to protect the heart if a patient has a different electrolyte that's severely imbalanced. Next, when we're giving calcium, always consider the fact the patient might be on a calcium channel blocker, and that might throw a wrench in whatever we're planning to do with giving the patient calcium. Next, we have magnesium. The terminology over here is hypomagnesemia and hypermagnesemia. This is again available PO and IV. This is another electrolyte. It's required for many bodily functions, but probably the most tested on for you to know is that it's a smooth muscle relaxant. It's a smooth muscle relaxant. The indications for this are to use as laxative and obviously for low magnesium level. It is used off-label for a few different things. First of all, it's used for asthma exacerbation. Since it's a smooth muscle relaxant, if in asthma where the bronchi are really constricted, this relaxes them. Instead of them being really tight, this relaxes them. Same thing with the uterus. If a patient's having preterm contractions, those are contractions, that's a tightness of the uterus. This is a smooth muscle relaxant. This will relax the uterus. It can also be used off-label for certain arrhythmias. When it's given for any of the indications I just mentioned, those are always IV. Don't ever think you can just go to the store and get some magnesium for an acute asthma attack. Next, monitor for magnesium toxicity. This is a big one to memorize. Any patient who's receiving magnesium via IV always needs to be continually monitored every 15 or 30 minutes or so. Their DTRs, their deep tender reflexes, and their respirations. Because it's a smooth muscle relaxant, we want to make sure they're not getting relaxed too much to the point that they stop breathing. Finally, we have sodium bicarbonate. Sodium bicarbonate, again, is available PO and IV. Sodium bicarbonate is actually part of the acid-base balance system in our body. Sodium bicarbonate is available as an antacid. That's what Alka-Seltzer is. And it's also available in an IV to give it to balance out when a patient has an abnormal pH, specifically when they're acidotic. It is also used off-label for hyperkalemia or other cardiac issues to balance things out in the heart. The treatment of when patients are being treated for this, we're going to be carefully monitoring ABG, ECG, and electrolytes. If anyone has any questions, please reach out. Please subscribe to our channel, like our video. Here are the references, and have a great day.